Welcome all. Welcome to this webinar hosted by Eaglet Eye in close collaboration with No7. And it's our absolute pleasure to welcome you here on this webinar that looks at the powerful combination between the eye surface profiler and the Onefit MED scleral lens. And my name is Arnold Snapvangers, and it's my pleasure to kick off. We have more than 150 registered people from, I believe, more than 42 countries. So a very international group of people. Welcome all. I encourage you, when you have a question, use the chat, please. And all will be answered, but we will try to do so at the end of this webinar. But please go ahead and use the chat. And so let's get started. So our guest of honor is Cian Gildea, and he's an international speaker, educator, and passionate person for specialty contact lens fitting. So we could not have a better speaker here than Cian. And his dedication for specialty lenses is well brought forward by his various fellowships of the Association of Optometrists in Ireland, of the International Association of Contact Lens Educators, and those of the British Contact Lens Association. So a wealth of experience, and Cian has also been fitting with the eye surface profile for a good number of years, so also there deep and wide experience. So thank you for freeing up your time and spending your time here and sharing your experience with the participants. And I will kick off with a short introduction, and then it's my pleasure to hand over to Ian Sexton. He is a professional services manager at No7, and he will give more information about the Onefit MED lens. And then we'll go to Cian Gildea, who will talk about the clinical applications, some case reports, etc. So basically, our aim with the eye surface profiler is to create a transformation of specialty contact lens fitting. And I will very briefly explain how we want to achieve that. So what is the background of our company? So it was Professor Takeda, a Japanese professor, who published in the late 80s a seminal work on profilometry. This is the technology at the basis of the eye surface profiler, and ocular surface measurements. And this was then picked up by Dr. Frans Jongsma, who is the original inventor of this device. And end of the 90s, he had his device ready, his invention ready, and it's under the name of the Maastricht shape topographer. And this was then picked up in the early 2010s by a group of engineers, out of which came Eaglet Eye, the company that I'm a part of as well, and was lucky to co-found. And but scleral lenses are actually going back a lot further. There's even some early drawings by Leonardo da Vinci in the 16th century, where he describes optical power of the cornea and the function of the eye. And the first sclerals were actually already produced in the late 19th century in Germany. This then in that time they were made from glass, and this then was transformed into PMMA devices in the early 40s, and it is much later in the 70s that and it's thanks to new materials that were introduced into for contact lenses that the modern scleral lens was born. It took a long time for the scleral lens to really take off. It was really a niche kind of product used by some very specialist fitters. And it is at the beginning of this century that things started to accelerate, and it is this highly effective way of particularly fitting and restoring sight for pathologic eyes. So it's all about, scleral lens is all about not touching the cornea and the fit is done on the sclera. And so the shape of the sclera before the invention of the eye surface profiler was done with a slit lamp. Slightly before the invention, also OCT was made available, and some corneal topographers, of course. But corneal topographers, in the word says it, they had their limitations of going beyond the cornea. But the essence of our device and why we make an essential difference is that research has shown, and it's been published in many publications, is that the corneal shape and the scleral shape often are not correlated, meaning that you cannot extrapolate from the corneal edge of the cornea out to predict the shape of the sclera with sufficient accuracy to fit a scleral lens, particularly on pathologic eyes. And this, of course, is where the eye surface profiler shines. So the eye surface profiler measures the full cornea, limbus to limbus, and then a large part of the sclera as far as the eyelids are held open. We measure real height data, and so have no extrapolation needed. And it allows you not just to measure the healthy surface, but also if there are puncticulae or scarring or all kinds of exceptional surface or the characteristics, they can be measured with this device. And so our key message is that we take the guessing out of the whole scleral fitting process. So just to kind of bring it home, what we used to deal with when we had corneal topography versus to what profilometry gives on the right. And as you can see, it's almost a complete surface of the eye as far as it is exposed, is measured with the device. And you see, of course, in detail that this is a keratoconich patient with a central cone on the cornea, but also some significant irregularities on the scleral shape. So the eye surface profiler is a single shot device that measures up to 20 millimeters. And we do so creating about data, a 3D map of the eye of about 500,000 data points. And so we do that for the cornea at 2 micron accuracy and for the sclera at 10 micron accuracy. The way the measurement system works is that you instill fluorescein onto the tear film. We flash from 2 sides. We flash vertical line patterns of blue light, cobalt blue light, onto the eye. And when that blue light hits a fluorescein molecule, it gets scattered back in all directions. And that means that some of that light will actually be captured by our camera. And it doesn't matter whether it's on the apex of the cornea or at the periphery of the cornea or on the sclera. Wherever the blue light hits the fluorescein, it will scatter light into our camera. And that is what you see on the picture in the middle. You see an equal coverage across the whole front surface of the eye. And that then is what you see on the far right image there, is then transformed into a 3D height model, these 500,000 data points that I mentioned before. We do more than just measure the eye. This device is taking care of the whole fitting process. So taking a scan, step 1 is just one. But it also gives you the software to analyze the data, to discover the specific qualities of the surface that you've just measured. And this is very important, and this is also, of course, where number 7 comes into play. We collaborate with many different lens manufacturers. And so together, we develop first lens fit algorithms, and they basically match the front surface of the eye with the back surface of the lens, and then basically come with a single measurement, with a single calculation they come with the lens order as it should be ordered. And the last bit, step number 4, is comprises of a system where you can push out that order, including the measurement data, to that lab of choice, and allows them as well to profit from the height data. So the measurement process is you need to instill fluorescein, and so the lubrication of the eye is important. It's a single shot measurement, so you need to hold open the eyelids in order to get maximum vertical coverage as well. And you're in full control, and you can point and align the device and fire. And so here is a short video of what an operator would see on the video. So you align the device, center it on the 2 Purkinje dots, and there's 2 dots here that you use to center. I will play that one more time. So the eyelids are held open, then the operator centers and focuses with these 2 dots. And when those dots are right on top of each other, the image is at perfect focus distance, and after this, you can process that into the height data and all the maps and parameters that you need to fit the lens. Right after you shot those photos, you will be presented with quality indicators, these 3 traffic lights that you see highlighted here. And they cover focus, centration, and coverage. So these are the 3 critical elements that will determine whether a measurement is good enough to fit a lens on, or whether you should, the patient is still in the chair right in front of the device, whether you should have a second go. So all of that means that you can have a very quick turnover of your patient. In just a few minutes, you will have both eyes measured, and they will be able to move on to the lens fitting stage. So analyze the data. So what you see is parameters and maps that you will see with your normal corneal topographer as well. But on top, of course, we have information about the sclera. And in the center here, you see a map of, in the center, you see the cornea. Again, this is a keratoconic eye. You see this red dot sticking out, being quite visual and presents itself very clearly. And then in the periphery there, you see the shape of the sclera. What many of our practitioners do is they actually use this to inform and take their patients along in the whole discussion about, so how are we going to find the optimal fitting lens for your particular eye? They've most often have never seen an image like this, and so if you take them along and show it to them and discuss how you are going to take the next steps, you will get a lot of appreciation from your patient. The biosphere elevation map is basically a relative height map, so it is the absolute height, and with the best fit sphere calculated by the software, subtracted from it. So anything that is either orange, red, or even white is where the eye is sticking above the reference sphere. And when the colors are green or blue or even very dark blue, the eye is lower than the reference sphere. So this is what you perhaps have seen with topography maps as well. For landscapes, terrains, you see here very prominently pinguicula sticking out. We have a depression here and a higher elevated axis in the vertical meridian. So we just mentioned this is that same image. We mentioned that pinguicula there. So this software and also the elevation map allows you to determine the position of the pinguicula vis-a-vis the apex, and also its relative height from the best fitted sphere out. and you can determine its width as well. So quite often, if you are fitting a scleral lens on an eye with punctula, it can be really tricky to get this right. But if you have the 3D height data, you can actually get the right information very accurately and very quickly. We have the scleral profile map, which is basically a quick way where you can assess the asymmetry of the sclera. So there's 4 flavors from left to right. Spheric is just a single color, toric 2 colors, quad specific 4 colors, and then this irregular is this hash marked pattern, the yellow, and indicating that it is more irregular than the shapes to the left. The first lens fit algorithm, we have a menu with all of these different labs and lenses. There are about 50 lenses connected right now. Today we focus on the Onefit MED supplied by No7 in the UK, but also in Europe. And you basically select the one that you want, you click on calculate, and this is where that matching is done between the front surface of the eye and the back surface of the lens. And then you can basically, after you've done the collect, you can use the direct connect to push out the order. And in this particular case, it will push it out to the Onefit MED fitting tool. This is an online fitting tool, and it will upload all the relevant data to this online fitting tool. But Ian, no doubt, will explain that in further detail. And with that, Ian, it's my pleasure to hand over to you.
Brilliant. Arno, thank you very much for the introduction and for the chance really to talk to everyone this evening about the Onefit MED. I've fitted lots of different scleral lenses throughout my career, and I find the Onefit MED is pretty much becoming my favourite. And Cian and I were talking about this earlier because of how easy it is to actually adjust the lens if we do need to make some adjustments based off of the data that we've received. So the features of the Onefit MED really is that we have complete control over the whole of the lens in really quite a very predictable fashion. So we have 4 independently controlled designs. We have a variable amount of toric periphery. We can use the front surface toric feature to correct any residual astigmatism that we might find. There's also an oblate geometry option available for our post-graft and post-refractive surgery ectasia patients. And some of the things that I've started to use recently is the quadrant-specific edge and limbal zones. So if you've got some of these quite complex ectasia with perhaps a tilted or twisted graft, and you need to alter the clearance in different quadrants, this is something that is completely available within the Onefit MED fitting tool. And we also have controlled peripheral recess, which, as Arno touched on, is the ability to notch out or actually fit the lens around a pinguecular or a glaucoma shunt or a stent, something like that. So what we want to do with this lens style, and this is one of the kind of the major features, is really to maximize the oxygenation of the cornea. And we do this by minimizing the tear layer thickness to around about 150 microns. And we also tend to, as we're manufacturing the lens, keep it to around about the 250 microns of thickness. Now, we can manufacture this in 100 DK material, the Optimum Extra from Contomac, or again, for the post-graft patients who may be more option dependent, we can have it manufactured in the 180 DK material, the Infinite from Contomac, which has a very low flexion, a very similar rigidity between those two materials. So these are the 4 zones that we have complete control of within the lens. So we can alter the central, so the actual sag height of the lens, and alter the M zone, the mid-peripheral, change the height of the limbal zone, and also the edge. So if we're actually fitting this lens without the advantage of having the ESP, then these are the kind of sags that we would perhaps start off with. So for a normal eye or post-refractive surgery, around 4,000 microns. As we increase the depth, as the cone becomes more prominent, we'd increase it between sort of 4,600 to 4,800. And then for these really high grafts, very advanced KC patients, then we're looking at sags of 5,000 microns and above. So these are the kind of clearances that we're looking for on initial application. So once we've ordered a lens based on the data from the ESP or from our fitting, patient comes to see us to collect. When we first pop that lens on, we're looking for around about 250 to 300 microns of clearance, as we would do with many other scleral lenses. That clearance reduces as we move out towards the edge of the lens. So when we're getting towards the limbal zone, we want about 100 microns. I normally allow my patients to settle down with the lenses for about 45 minutes or so after initial insertion. So pop the lenses in, send them out with my healthcare assistant to check clearance. She then sits them down in the waiting area for 45 minutes. We remeasure the clearance after 45 minutes and then do any over refraction or any adjustments to the edge or the design that we want to. The lens will continue to settle back a little bit after this. And this is why we like to have these sort of 200 microns of clearance at the end of that 45-minute period. We know as the patient starts wearing the lenses that that will settle back possibly another 50 or 75 microns. So these are the adjustment areas. We can alter the sag. This is the mid-peripheral, the limbal, the edge. To help us with the selection of the lenses and to see really where we need to make the adjustment, there are laser engraved circles which actually coincide with the mid-peripheral zone and the limbal zone. And when we assess the lens, for those of us that don't have access to OCT or are just using the slit lamp, we can still use the fluorescein within the fluid layer to compare to the lens thickness. Diagnostic lenses within the fitting set are 230 microns. So we know on initial application, we want parity or just above with that fluorescein layer. If we do have access to anterior OCT, then we can measure it much more precisely and have a look. And this is what we tend to do at the hospital that I work in, is my HCA will actually measure that clearance for me and then bring those results in. And I'll make a decision whether I need to make any adjustments to that sag at that initial point. So we can adjust that height on that initial diagnostic lens up to 6,600 microns. So for those really protrusive grafts or keratoglobus globus where that cornea is really sticking out, we've got very high elevation, and we can really increase the sag of that lens to a very deep lens to make sure that we clear that. But we still have the adjustability within the M and the L zones to make those micro adjustments in that mid-peripheral and limbal zones. So when we make adjustments to the sag value, if we change the sag from a 4500 because it's a bit close and we increase it to 4700, the relationship between the sag, the M zone and the L zones is completely linear. And this makes the lens very easy to understand. So a 200 micron sag change will change the M zone by 100 microns, so 50%, and change the L zone by a quarter, so 50 microns. So if we go 200 microns with the sag, we get 100 microns on the M and 50 microns on the L. And this variation in height is precisely at those circular areas. So the mid-peripheral zone is 9.5 millimeters, and the L zone is at 12.5 millimeters. And you'll have height adjustments that will be exactly at those points. And that will be where it's maximally adjusted. And we can make adjustments between plus or minus 300 microns in each of those zones. So with these M and L zones, we can make adjustments that are coincident with each other. So we can increase both of them, we can decrease both of them, or we can make opposite adjustments. So we may need to find that we increase the M, but perhaps we need to reduce that limbal clearance and bring that in a little bit closer if that's a nice kind of pointed central cone. And this limbal zone at 12 millimeters, again, we can increase that or decrease it in 300 microns in either direction, and we can make that coincidence with the M zone if we wish. So when we come to the edge is where I think some of the adjustments, and this is where the ESP really comes in, because it gives us this toricity that we use at the edge and enables us to fit this lens much better. Now we can adjust the edge by observation, we can look for blanching, we can look for shadowing around the edge, and we can make these adjustments on this curve independently of each other's of the either meridians. So we can increase the flat and lift it right off if it's really digging in. We can do the opposite to the steep. And again, we've got plus or minus 300 microns of adjustment. So there's a significant amount of adjustability built into that edge. And certainly with some of the research that we've seen, there is a significant amount of scleral toricity, and it's really showing up with the ESP. And this is where it really gives us a big advantage in adjusting this amount of edge toricity. So we use the toric periphery because the sclera is generally very toric, and it becomes more toric the further away the limbus we go. So with these larger 16.0 and 16.4 lenses, we're likely to encounter more scleral toricity, and we'll need to use a higher amount of toric periphery. Often, if we don't, the lens will decenter. If the lens is decentering, we can get lens fogging. The patient becomes aware of the lens, it may flex. And we'd also use the toric periphery as a stabilization method for front surface toric, and also to position this controlled peripheral recess. We mark the flat axis of the toric periphery with these dashes, so you can again see precisely where that flattest meridian is, and you know then 90 degrees opposite is exactly where we would make the steep adjustments. So this is a fairly extreme example of blanching. So you can see it's blanched all those vessels, created some fairly significant hyperemia. We would lift this probably by 100 to 150 microns to allow that lens to stop digging into that conjunctiva and lift off of those vessels. So this is really showing you all those values that we can adjust completely. You can actually see those circles on OCT as little depressions. Oblate geometries, which are available for our post-graft patients, again, are precisely controllable, 70, 110, 150, and 190 micron steps, and it will be exactly that amount of reduction. So when we put these changes into the calculator, we can put in the lens that we've got, put in the changes that we want to make, dial in those different adjustments and recalculate, including the over-refraction. It will then calculate exactly the new lens to be ordered, including the power, and show you the variation in tear film thickness. And if you wish and are able to, you can actually estimate the DK over T at the eye if you're concerned about corneal oxidation and want to keep it above that Harvett and Bonanno criteria. So it is a really easy lens to fit. It's really very predictable. Adjustments are very precise because of the positioning of the rings. The zonular relationship is very linear, and the tool does help us to really visualize what's happening. And as a bonus, the calculator will work on your phone. I'll now hand over to Cian. Thank you very much, and enjoy the rest of the presentation.
That's great. Thanks, Ian. And thanks, Arnu and the Eaglet team for inviting me to speak this evening on something that I really enjoy. So I think, Ian, you were just saying earlier on about in terms of scleral toricity. So the scleral shape study group, they found that only about 6% of patients had spherical scleras. There's about 30% had regular toric, and the rest are aperiodic toricity. So basically no rhyme or reason to their scleras, which makes it so much more important when you're fitting lenses. To get that accuracy right. I think from one of the things that's mentioned an awful lot about fitting scleral lenses is the art and science of fitting a scleral lens, when with the amount of technology that we have today, it should be more weighted a lot more before towards science. I mean, you don't want to be going into a big operation and the doctor is saying to you, well, we're going to use the artful approach here. you want some cold hard science behind it. So I think I got my ESP in 2015, if I'm correct. And Direct Connect wasn't up and running then. So the Direct Connect function is, it's huge. It's amazing innovation, and the fact that then you have access to multiple labs, you can sit down, you can discuss with the patient, you can get them really involved in the process. And I think a combined approach to someone's healthcare gets them much more involved, and has better outcomes for the practitioner and for the patient as well. So my main frustration was chair time. You get a patient in, and back then actually as well, the majority of fitting sets were all spherical landing zones, and you might have had one toric lens in the fitting set. with just one SAG. So if you were lucky, you'd have a minimum of 2 lenses on eye. So you'd put the first lens on, and if you were lucky, you got a good, an acceptable SAG. Then you assess the edge, and then you have to put the next lens on, the one with the toric periphery, to make the fit better, etc. But in reality, it didn't work like that. You were maybe putting on 5 or 6 lenses onto an eye. You can see the patient getting very frustrated, and it doesn't reflect very well on you. They think that you don't know what you're doing, basically. So being able to take a scan, talk them through it, being able to highlight to them that these are potential pitfalls. Actually, you know what, your sclera is extremely tricky. This is going to take a couple of more lenses than we would have thought. At least that way, they know what they're doing. And I mean, it's different to fitting corneal lenses. A corneal lens, you'll get in and out of an eye very, very quickly. It's not that onerous on a patient either. Whereas with a scleral lens, insertion and removal is a little bit more cumbersome. They have to do the whole bending forward, etc., etc. So the least amount of lenses that you can put on an eye, the better. And that's important as well when you're assessing fit. Actually, sorry, I want to ask a couple of polls here. So yeah, do you want to launch those 2 questions? So just the first one, do you already fit scleral lenses or not? And so I haven't started yet, but you're going to get started. And the second one is, I already fit scleral lenses. Okay, so we've a good 2/3 of the audience are already fitting scleral lenses, which is amazing. That's great. And a third are about to, hopefully after this presentation, they'll start fitting lenses soon enough. And the next question, if you can launch that one. So this question is around how many scleral lens fits would you do in a month? 0 to 1, 2 to 5, 6 to 10, or 10 plus? Now, and so I'll say that this is new fits. And we'll have a look at the results now. Okay, so 0 to 1, 36. So 2 to 5 is 36, 6 to 10, 11, and 10 plus 17. So the reason I asked that question is they've done a study on how long it takes to become proficient in fitting scleral lenses, and they estimate 60 lens fits before you come proficient at it. And if you think about, say you're doing 5 fits a month, which that they're good numbers, that would take you about a year. If you're doing 1 to 2, it can take you 2 to 3 years to get up to that level. So basically, it takes time to become proficient. You need to be seeing relatively high numbers, but you can streamline that process an awful lot by investing in technology like the ESP. These are just a couple of studies basically looking at the association between corneal toricity and scleral toricity. So they thought previously that there was no real correlation, but they've actually found out now that there is a correlation, especially if somebody has corneal astigmatism of over 2 diopters. There's a higher incidence or chance of having toricity in your sclera. And one of the studies went on to say basically astigmatism isn't restricted to the cornea. It should be considered more of a property of the globe. The second study here basically goes on to say that the scleral profile in keratoconic patients is more irregular, so more toricity compared to those in healthy eyes, and with more advanced disease, the higher the irregularity. So again, the main reason that I would fit in my clinic, so where I work, the main reason that I would fit lenses, it's ectasias, it's keratoconus, PMD, irregular corneas. This is the study that I was talking to earlier on. So the scleral shape study group, they classified the spherical, regular, toric, asymmetric, etc. They also found that if somebody's cone is outside the central 1.25 millimeters, they have a much higher chance of having a higher toricity in their sclera. And the other one is that the asymmetry tends to be in a quadrant specific location on the same axis as the cone. And I'm sure people who are fitting ectasias already know that most cones are decentered inferior temporal. So again, you're going to get higher amounts of scleral toricity. And these next ones, so this is a patient that I saw the other week, and it's just kind of reaffirming what those studies have said. This patient, bilateral keratoconus, much more severe in the right eye compared to the left. This is his left eye. You can see his cone in the middle of the picture there, and chord length of 15, and the difference is only 130 microns of toricity. So not much to talk about. And if we go on to the next slide, this is his right eye. I've gone out to 17 millimeter chord just to emphasize the point here, but you can still see it. He has a much more advanced cone, and his scleral toricity is gone up to 540 microns. So that gives you a bit of an idea of, well, number one, it makes a huge difference being able to show this to the patient. But if you're dealing with advanced disease, the chances of the sclera being toric, very, very high. So you can go in with a bit of knowledge saying that, yes, I expect this to be a higher amount of toricity, but how much, that's a guess unless you have something like the ESP. So I have 3 case reports that I want to talk to you about. The first one, he's a 25-year-old male. He works as an administrator, struggling with his vision. His first pair of glasses were only 2 years ago. I couldn't get over that. Because his vision was so poor. So we're going to go on to the next slide, and we'll see here. He had grade 4 keratoconus in the right eye, grade 2 in the left. His right eye was too thin for cross-linking. And his left eye had epithelium off cross-linking in April of this year. He was referred by an ophthalmologist for a contact lens. And the right eye, essentially, if he didn't get on well with the lens in the right eye, if we couldn't get a lens to fit, he was going to be put forward for a DALC or a PK. And obviously, if we can avoid a big surgery like that, that's great outcome for everybody. But that's his right eye in the top right corner. You can just see how advanced that cone is. So essentially, they're the 2 maps. So again, I suppose highlighting the point again, we can see the amount of toricity in the right eye with a way more advanced cone compared to the left eye. So we'll look at it. Well, my process is I'll look at a few different chord lengths. So most lenses begin to start landing around the 13 mil zone. So you can see what the level of toricity is there. I'll talk to you a little bit more about the features on the Onefit MED and how this can actually help. And then you look at the 15 millimeter zone, and then a lot of the times I'll go out to 17 as well, just to check the levels of toricity. This can help you decide on the total diameter that you're going to use. So the OneFit MED comes in a 15.6, a 16, and a 16.4, and then you can get the OneFit MED Plus, which comes in a 17. So it really does have all the bases covered in terms of your total diameter. So yeah, so the direct connect is great. It'll advise you on your trial lens, so the best lens to put on the eye. If it falls in between two sags in the fitting set, always go for the higher sag, because again, whenever you're estimating a lens, it's always better to go on the higher side than the lower side, because at least if you're on the higher side, you have a much better chance of assessing how much you need to bring it back down, versus if you're on the low side and you're getting touch, you don't really know how much you should lift it by. So one of the best things about the OneFit MED and Direct Connect is, again, as Ian was saying earlier on, you get a very, very good visual of what's going on with the lens and what changes you need to make, and it makes a lot more sense to you in real time there, where you can actually see what's happening to the lens. And one of the great things about the Direct Connect is you have the lens, or you have the lab involved, so they know what's going on. They've seen the scans. They see, they're producing the lens. They know, they're in the story as well. So if I was having issues, and the crowd at number 7, so Ian and Tony, or Kevin, I mean, he's they're absolutely fantastic. They have a wealth of experience. So if you're taking pictures, you can feed that back to them. They can give you like unbelievable advice on your fitting process too. So that's actually his right eye. You can see that there's a lot of fogging in the top left image. I'm not. That was after, I think, that's after 2 weeks. Not going to do anything about that yet. A lot of the time, fogging will spontaneously resolve. It's just the eye adapting to its new environment, basically. He isn't noticing any issues with it either. So again, leave well enough alone. But if he was complaining of it, looking at that there, you could reduce the mid-peripheral clearance, so the M value on the lens. You could reduce the central sag a little bit. And then obviously looking at limbal vault, making sure that the edges are well aligned. The two inferior pictures there, the lens was very well aligned. So there's no issues. But again, this is something that I'll just monitor for now. This is the next case. Quite a sad and frustrating case for the patient. She's a 50-year-old female. She presented to the emergency department back in October 21. So two years ago was when she first started with this journey. And the chief complaint was blurred vision, but she was still unaided. She was seeing 675. So that's 0.8 or 20/25. And she was given a tentative diagnosis of granular dystrophy. So in March 22, her unaided vision had dropped. Her right eye was 636, left eye 624. Her aided vision was 624 and left eye is 612. So 612 is just driving standard in Ireland and the UK. She had a Schirmer's test done, only 1 millimeter after 5 minutes in the right eye, 2 millimeters in the left. She had a negative Sjogren's workup. She had decreased corneal sensation. She had epithelial defects. She was giving steroids, plugs, autologous serum drops, and she was given a diagnosis of neurotrophic keratitis. And then, so later on in April of 22, she can't function. Her vision is completely shot at this stage. She can't drive. She can't work. She has a neurotrophic ulcer on the right eye. And all she had been managed with at that point were soft bandage contact lenses. They kept on falling out. They were doing absolutely nothing for her vision. And then she came to see me in October of this year. So you can see that's the right eye. You can see the scar quite clearly there. In the left eye, it's a little bit harder to see in this picture, but you can actually see some issues in terms of the epithelium, some old SBK and things like that. And that's her right eye, so not so bad. This is on a pentacam. There doesn't look like there's a huge amount of noise there. The left eye, a little bit more noise, but you get a really good appreciation of what effect the cornea was having. If we look at the topography, so the Placido disc, you can see there's an awful lot of noise, an awful lot of distortion, and that really goes on to show, you know, why she was seeing so poorly. That's the left eye. Not as bad as the right, but still not functioning as well as she could. So I got her in and we took some eye surface profile measurements. So there's the right and the left eyes. So yeah, so Arnie had a really, really nice, well circumscribed pinguecula, the textbook pinguecula, but you know, they don't often present like that. A good option to go with is actually the tangent angles map, and that really, really highlights the pinguecula there. She had quite small eyes, so I went for a smaller diameter, so 15.6. It wasn't like I was trying to get over a really, really big cone where I would usually go for a larger diameter lens. Ocular surface disease patients tend to go for larger diameter lenses as well, just because you're protecting more of the ocular surface. But you know, for her, a 15.6 was the right choice. So that's the fit of the lens, basically from the ESP measurements. So it was really, really well aligned. She's delighted. She says she's a new woman. She's back to work. She's back driving. And when she came in to collect to get lenses, you know, I was talking to her as well, and she's over the phone just to see how she was getting on, and her husband was saying she's like a new woman. So it's amazing the difference you can make with these little pieces of plastic. So yeah, there's just all the quadrants. So a nicely fitting lens. This is a great feature of the Onefit MED lens, is the controlled peripheral recess. So she had a large pinguecula. There was no escaping it. We had to do something to address it. And again, the fitting tools that are available on the Onefit MED are very, very self-explanatory. You can see the two blue hash marks there. That's essentially highlighting where the flat meridian was. And then based on where the flat meridian was, you control the position of your recess. Then you can select the depth, the chord, etc. And it tells you exactly, you know, you put all that in. It tells you exactly what to order. And there's the right eye with that final notch in, so you can see it going around the pinguecula, and it's, you know, nice and quiet and no issues. This is why I check a chord length of 13 first of all. So you know, you can make it as simple or as kind of as complicated as you like when you're going with these lenses, with the Onefit MED. But you'll see more and more now, again, the amount of toricity. People think that toricity is kind of confined maybe to maybe 15 millimeters or and beyond. But a lot of the times you have to check, you know, where exactly is this toricity beginning, because that's going to improve the fit of a lens. If a person exhibits an awful lot of toricity at, say, maybe a 12 or a 13 millimeter chord, you can actually start adjusting the limbal zone in different quadrants to essentially get a better fit. Because if the toricity starts further in, you need to start addressing that, because if you don't, and if it's a spherical limbal zone, you're going to get areas of lift, and then you're going to get areas that are closer to the limbus, and that can cause issues with edema. It can cause issues with lens fit. If you have excessive limbal clearance, and every time a lens or a person blinks, the lens is essentially going to be like a basketball. It's going to be popping up and down, and that can cause issues with edema. So this is the third patient. We're coming up now to time. So she's a 43-year-old female, advanced keratoconus in the right eye, grade 4, left eye, grade 2. Her refraction, right and left, you can see, but in the left eye, she actually has very, very good vision, considering her cone. So it's just a soft lens for her left eye. That's the right eye. So really, really advanced. I think K max of 73, almost 74 diopters, average K of 63. So, you can see in the dotted area there in the pupil, there's actually just a small amount of toricity. That's why her level of vision is actually quite good, even with a soft lens. So we just looked at fitting the right eye. She actually, so at a 13 millimeter cord, she only had about 220 microns of toricity, and her sclera, for how advanced her cone is relatively symmetrical. Again, if you don't have the technology, you'd rightly assume that this person will have quadrant specific toricity, but again, you're going in with a guess. So we went with the Onefit MED, direct connect. You plug in your numbers. That was the final lens. So really nice fit. She's very, very happy. I suppose on a closing note, so I work in a public hospital as well, as well as a private clinic. We don't have the ESB in the public hospital. We have it in the private clinic. I'll get to the same endpoint. I'll get a lens that fits, but when I'm doing it in the public clinic, I'll tell the patient, it's going to be 5 to 6, possibly 7 visits before I get a lens finalized that we're happy with, etc. Whereas in the private clinic, I usually tell them, you'll come in for your initial consultation, you'll come back then for a dispense and a teach, and then we'll check you up afterwards. So they're going home with a lens after their second visit, basically. So it really, really speeds up the process. And I think that's me. I think that's the end of my slides. Oh yeah, there's the rest. Actually, yeah, sorry, for her on the right eye, she does have a tiny pinguecula. We'll see how it goes. But we might add a CPR there as well.
Okay, thank you very much, Cian, for those 3 cases and your personal experience in fitting scleral lenses with the eye surface profiler. We have a number of questions. Elena, is there anyone that? Yeah, go ahead.
So there was one that I saw in the chat earlier on, Rodolfo. So Rodolfo was asking about one of the concerns is reproducibility of the measurements. So if they're already in scleral lenses, studies have shown that stopping scleral lens wear for about 48 to 72 hours, the sclera will have come back about 80% of what its normal shape should be. So I would advise patients to leave lenses out for a minimum of 72 hours before I take measurements. I'll get them to start lubricating their eyes before they come in. I usually, if they can't stay out of lenses, we'll usually do one eye at a time to take the measurements. And what I do is I'll always use anesthetic, because it just keeps them a little bit more comfortable. It reduces reflex tearing as well, so you'll get a more accurate measurement. And I use an awful lot of a high viscosity, sorry, not high viscosity, a drop with hyaluronic acid. So 2 drops that I mentioned that I like to use is Hylo Forte and Thelos Duo. I think you'll find one that works well for you. And I will probably take about maybe 6 to 9 measurements on each patient, on each eye, because I'm looking for reproducibility, as Rodolfo correctly pointed out. And the more scans you take, you get them to blink in, then you have more data, and you can choose which one is going to give you which is the best scan. A good way, obviously, you have the metrics that you were talking about earlier on, the focus, the coverage, etc., and things like that. But you can go into the tangent angles map. You'll see if there's any artifacts in that map that can give you a good idea if you have a good scan or not. And then the other thing is if you look at the actual grid as well. So if you're looking at the grid for any areas that are drying out or anything like that, any disturbance in the tear film. So you can get a very good quality map that's reproducible by employing some of those techniques. You do need time to. It's like anything, the more time you spend getting good maps, the easier it is for you and for the patient, and the better the outcome.
Excellent. Cian, there's another question from Masou saying, how many minutes do we need for over-refraction after inserting the scleral lens?
Ian, yeah, I think people have different preferences. What I will usually do is I'll take my measurements, I'll put the lens on, I'll probably talk to the patient, kind of what to expect, talk to them maybe a little bit about their scan. Have a look at the lens, make sure that it's fitting generally well, happy with the sag, etc. Kind of gross assessment. And then I'll actually do a refraction there and then. So I would say I would probably refract after maybe about 10-15 minutes. Then you can send them out. You can send them out and let it again settle. I usually let it settle for about 30 minutes and then get them back in. You can double check refraction again quickly then. So I suppose that's just my process. But everybody will have their own preferences.
Yeah, I think that's true, Cian. It depends on how the clinic works. So with my clinics, because I tend to run 20-minute appointments, I'll normally let the patient sit outside. So lenses will go on, check clearance, and then I'll let them sit outside for about 35 to 40 minutes, because then I can slot them back into my list. Easier that way. It's just how it works for me. But there is a lot of variation within practitioners and how long they let them settle. But yeah.
Yeah, I think I think it's how your clinic runs. You know yourself how, like, when you're going to get time. It might be a case that if there's another patient waiting for you and they'll be waiting for a while, you might send that patient out first, get the other one in and started before you bring the other one back in to refract. So
yeah.
Okay, there is a question from Anne Peik about the eye surface profiler, so I'll take care of that. She asks, do you need a dark room for a measurement with the Eaglet Eye? And the answer is, well, you need to have a light controlled room, in the sense that, as I mentioned at the start of the presentation, the camera captures scattered light. So if you have a light source that creates a direct reflection of the cornea into the camera, that direct reflection will be much stronger than the scattered light. And therefore, any light in the source in front of the patient needs to be avoided. And daylight definitely cannot be used. But ambient light in the room is quite acceptable. So it definitely doesn't need to be pitch dark.
Can I add one thing to that, Arnie? Watch out where your PC monitor is, okay? Because say I had it set up where the patient was in front of me and the PC monitor was off to the side, and it was quite bright, and it was actually causing it was kind of casting a little bit of a shadow. So I basically adjusted it, and that kind of dealt with the issue. But yeah, you need to pay attention of other light sources.
Yeah. Okay, thank you. Then another question from Rodolfo saying, well, how many refits do you have when you fit with the ESP on average?
As in how many lenses before I will get to my final lens?
Yes.
I'd say 1.5 to 2 lenses max before I'm at my final lens. Yeah. Okay,
thank you. And then also another question from Rodolfo. Thank you, Rodolfo, for asking all the good questions. I really appreciate it. So he says, yeah, I always, so apparently Rodolfo has experience with iSource Profiler. So welcome. He says, I always need, or do you always need an assistant to hold open the eyelids? Here I can say something in general. Quite a few of our users, they have somebody holding open the eyelids, but it's not necessarily so. And Cian, you are one of the people who does it all by himself, huh?
Yeah. So Karen was in for the Euroskull in Dublin a couple of weeks ago. So she got to see my technique. So what I'll do is I'll get the patient to hold down their lower lid. I'll get them to look down, and I actually get a cotton bud to lift the upper lid up, and you get really, really good results. You just need to tell them, sometimes they'll pull their lower lid down here and then you'll miss some of the nasal portion. You tell them to put it in a little bit closer, and I don't have any issues. If it's particularly difficult, I can always run out and ask somebody to hold lids, but that rarely happens now.
Okay, thank you. And this is seconded by David Berkow. Thank you so much, David, for help. David is one of our practitioners in Israel. So, okay, I have a question from Keith Tempany. How long does it take to get a good capture in the first place? You say you make a habit of taking multiple images of every eye. And yeah. From Eaglet Eye, so from metrology, so the science of taking measurement, it dictates that you should never rely on a single measurement, however good it might be, because you always want to compare it to several other good measurements to be able to see what is the situation with this eye. But yeah, so I'm coming back to Keith's question. When do you get a good scan? Is that the first time around or the second? What is your experience on average?
It depends. Like if it's total time spent, I would probably spend about 5 minutes per eye on gathering images, and that's between setting the patient up, putting their drops in, and then taking measurements. What I'll do is I'll take 3 measurements, then I'll put more drops in, more fluorescein, take another 3 more drops, more fluorescein, another 3, and then do that on both eyes. And it's probably 5 to 7 minutes per eye.
Okay. And then a final question from Herwig van der Kerkhof from Belgium. And so it's more general question. So how do you remove a scleral lens that is really stuck? Ian?
Yeah, Ian, go ahead.
I always remove the scleral lenses with a small sucker at 12 o'clock. If it's really stuck, then what I'll do is manipulate the lid under the edge of the lens to just push that sclera enough to allow an air bubble just to pop underneath that lens, and that will release that suction. But I must say, with the OneFit MED, it happens very, very rarely. It's not something that I've actually come across personally.
Yeah, I do the exact same thing as Ian. I'll always get, even when I'm teaching patients to remove lenses, I always teach people how to insert and remove with their hands. And once they can do that, then I give them the sucker and in the insertion tools. But if they break suction, first of all, the lens is going to come out much easier. I just see a question here by Chris asking, in Europe we don't have a OneFit yet.
Yeah.
I'm Dublin based and we get it from No7, no problem.
Yeah. Ian,
can
you say a few words about availability of OneFit in mainland Europe?
The availability, the OneFit is available in the European market. So I think if you would like to drop me an email, we'll share the emails at the end of the presentation, and then I'll pass that on to our European team, and they'll get back in contact with you to look at how we can supply that for you.
Wonderful. Thank you so much. Thank you, Cian, for all your energy and your expertise. Ian as well. Thank you for explaining the OneFit MED so clearly, and thank you all to our audience here this evening. We really appreciate that your presence. Oh, bear with me. I'm just here we go. And so we hope to see you soon at one of our future webinars. Please come to the events page of the eagleteye.com webpage, or subscribe to one of our newsletters. Same with number 7, of course. And we thank you so much for your presence. Thank you.